So welcome everybody. Thank you so much for attending this webinar, and hello to any of those who are going to watch it later on because it's being recorded. So we're going to talk all about the menopause transition and how to thrive during it and for the rest of your life as well. So this is me, Dr Juliet Balfour. I'm a British Menopause Society specialist and trainer with the Advanced Certificate in Menopause Care. And I've been a GP for over 30 years, specialising in women's health. And I'm a member of the British Menopause Society Medical Advisory Council. And I've managed to get money from the wonderful ICB and I lead the NHS Specialist Menopause Service for Somerset. I do lots of education for both healthcare professionals and women. I have a very small private clinic, but please don't write to me there because I'm not taking on any new patients. And if you want to follow me on Instagram, I'm at Menopause Health. So what are we going to do? I'm just going to move that out of the way. Okay, so lots to get through this evening. We'll see how long it all takes. Thank you very much for all of those of you who submitted questions in advance. Hopefully I'm going to answer most of those during this session, but hopefully we'll also have a bit of time for your questions at the end. So we're going to go through definitions because it can be quite confusing. What do we mean by all these lots of different terms? We're going to go through the myriad of possible symptoms. I'm going to talk a bit about two big things that happen to us as we go past the menopause. So I'm going to talk a bit about osteoporosis and cardiovascular disease. And then we're going to talk about what can help. We're going to talk a bit about lifestyle, CBT, non-hormonal options, how to protect your vaginal, vulval, urinary and sexual health. We're going to talk a bit about HRT. We're going to talk about female sexual desire and the role of testosterone. And at the end, how to talk to your GP and possible resources so you can read more. And you see, this is being recorded, so this is packed with information, but it's designed so hopefully you can go back and have a look at bits that you're interested in again at another time. So let's get started. So why are we talking about the menopause? So why is it important? So it's really important for us to know what to expect, what symptoms might get and how to manage them. And it's really important for our partners and families as well, because a lot of marriages actually run into trouble when women are getting lots of awful menopausal symptoms, and you know, it might be difficult looking after our children when we're feeling awful. Really important in our workplaces as well, and it's great that there are more people talking about menopause in the workplace now. And we know that 1 in 10 women who are working around the time of the menopause actually give up work because of their symptoms, and many more either don't go for promotion or go part-time, reduce their hours, or just find it difficult. They struggle to actually cope with work. Really important for our NHS. I think the NHS is run partially quite a lot by midlife women, and you know, we're losing a lot of our wonderful nurses and other people in the NHS because they're finding that the job is too stressful and difficult to do. Also important from NHS, from patients' point of view, because we spend a lot of money investigating women with symptoms that actually are menopausal rather than anything else. So women get sent to cardiologists and neurologists and psychiatrists, often for things that actually are menopausal and could be sorted out in other ways. So we could save a lot of money, and also because the benefits of HRT on our long-term health, we could be saving a lot of money down the line as well. So we're going to talk about symptoms, and it's important we prepare young women, but we mustn't frighten them. You know, menopause isn't always awful. It's great when you come out the other side, and it's not all bad. Sort of, you know, we stop having periods, we stop having to use contraception. A lot of women have a second career when they're not having such a caring role. So there can be good things as well as bad things. So there are a lot of issues at the moment. We haven't got enough good quality research into women's health, and this is leading to sort of polarization of views on HRT and a lot of misinformation on social media. So hopefully this talk will try and give you a bit of a steer as to what's evidence-based and what isn't. And we also know that there's massive inequalities in menopause care, and so a lot of women who can afford it are going privately, but obviously most people can't possibly afford that, and unfortunately some private clinics are actually going way outside the guidelines, so some women are actually not getting ideal menopause care anyway, even if they go privately. And we certainly know that patients who've had cancer, we're not giving them enough support at the moment, but there's a lot of work going in to try and educate doctors and breast care nurses and GPs about this. So we've got lots of work to do. So let's look at some definitions. So what is menopause? So this is just showing, a graph showing a little bit what happens with our hormones. Particularly, we're looking at the estrogen, the green, and the progesterone, the dark blue. So before the menopause, most of us have monthly cycles, and we have a fairly regular undulation and change in our hormone levels. Perimenopause, it goes all over the place, as you can see. And then postmenopausal, we settle down with low levels of both estrogen and progesterone. So the menopause is basically when our natural periods stop. So our ovaries stop producing eggs, and therefore we stop having the estrogen and progesterone produced in this regular monthly cycle. It's actually a retrospective diagnosis when you haven't had any natural periods for 12 consecutive months. So you go for a year without a period, think, okay, my menopause was a year ago. And the average for menopause in Caucasian women in the UK is the average age is 51, but we know that some ethnic groups can be a lot younger. But anything between your last period at 45 and 55 is considered normal, although we're seeing a lot more women having periods a bit later than that now. It's not as easy to diagnose as it sounds, because women may have had a hysterectomy, so we don't know whether their ovaries have given up. You may have had an ablation when the lining of your womb is zapped to stop heavy bleeding. You may be on contraception. You may be on the combined pill or the mini pill or the implant or the hormone coil, or you may already be on HRT because you've had awful symptoms. So often you don't actually know when your last period was. And sometimes it's not, if you average your age, it's not terribly relevant, because with each woman, it varies how long the symptoms are going to go on for after the last period anyway. So what's perimenopause? So we're talking about perimenopause a lot more now. And this is the time from the first changes in ovarian function until 12 months after the last period. And it can last up to 10 years before your last period. So if you think that I said that the average, it's normal to have a menopause any time between 45 and 55. If we go back 10 years from 45, that's 35. So some women in their late 30s are actually having perimenopausal symptoms, but they may not realise it. So early menopause, this is when your periods stop between the ages of 40 and just coming up to 45. And premature ovarian insufficiency, this is POI, this is when your periods stop below the age of 40. And actually, about at least 1 in 100 women have POI. And some women have a really, really early menopause, even in their teens. It's really important we pick these women up, because unfortunately, if you're without your estrogen, particularly for many years, less than the average woman, you're unfortunately at increased risk of cardiovascular disease. So that's heart disease and diseases of the blood vessels. And you're at increased risk of osteoporosis, thinning of the bones, and you're also at increased risk of cognitive issues compared to someone who had a menopause at the age of 45 or over. So with women in this situation, it's really important that we discuss HRT at least to the average age of the menopause, if it's not contraindicated, and we'll come into contraindications later. And it's also really important that we help these women optimize their lifestyle. So some people do have a really dramatic menopause and really dramatic symptoms. And these particularly women who've had surgical menopause. So surgical menopause is when your ovaries have been removed. And it's also worth noting that if you just had hysterectomy, but you've had your ovaries left in, they can sometimes fail earlier than if you hadn't had surgery. And then some women go through what we call a medical menopause. So they may have chemotherapy or radiotherapy that damages their ovaries. They may be on what we call adjuvant endocrine therapy, which is we give women who've had breast cancer. Or some women, we switch their ovaries off, for instance, if they've got severe endometriosis or PMDD. So those women, they can have menopausal symptoms too. So let's start going through the symptoms. So let's talk about the cognitive and psychological, emotional symptoms first. So it's important to know about these often come before the physical symptoms and may come on before you even realise that your periods are changing. So commonly, anxiety is very common, and panic attacks. And I find a lot of women actually start getting really worried about driving. Maybe they stop driving at night or driving on the motorway. Women stop wanting to go on a bus or a tube. They're quite common. Some women have mood issues. They may have a low mood or depression, or sometimes we call it loss of joy, in that everything's okay, but they're just flat and they don't look forward to anything. A lot of women tell me they've lost their mojo. You might become more emotional or easily tearful, or really mood swings, really irritable. And women who tend to get premenstrual syndrome, it often gets worse in the months leading up to the menopause. And I'm sure you've all heard of the term brain fog. So this is sort of an umbrella term for lots of things that can happen with our brain. So when memory gets worse, maybe problems finding the right word, concentration is less. And a lot of women have reduced motivation, and they also have reduced confidence and self-esteem. And you can see all these symptoms, you can see how they really affect people at work, not being able to concentrate, not being able to remember the name of your colleagues, not being able to present in meetings, lacking in confidence. It can really affect women at work. And this is, sorry, rather a busy, long slide. This is lots of physical symptoms. So your periods can change, and they may become heavier or lighter, or there might be a bigger gap between periods or a shorter gap, or you might miss periods. So that, if you're getting that, that's often an easy pointer that something's going on. But sometimes people don't get those changes for a while. And then you've all, I'm sure, heard of flushes and sweats. So you can get hot and cold sweats and hot and cold flushes, and these can be day and all night. And a lot of women get poor sleep. Now, this can be partly due to some women get these awful night sweats, so they're waking up soaking, have to change their bedclothes, have to change their pajamas. But other women, their sleep is disturbed without any flushes or sweats. And it's quite common in menopause to be able to go to sleep okay, but then you suddenly wake up middle of the night, 2, 3 in the morning, brains wide awake, start worrying, ruminating, possibly with anxiety and palpitations, and it takes a long time to get back to sleep. That's also really common and disabling menopause symptom. So a lot of women feel very tired. Some women get more headaches, and if you suffer from migraines, they can be a lot worse. And then some women get palpitations, breathing problems, feeling faint or dizzy. And then lots of women get aching muscles and joints. And some women think, oh, I'm just getting old, I'm getting arthritis. But often it can be due to lack of estrogen, because estrogen is an anti-inflammatory and can really help our joints. Then lots of things get drier. So you get drier hair, dry eyes, dry itchy ears, dry mouth. Some people get a burning tongue or a metallic taste in the mouth. And then these more joys coming, thinning hair. Lots of women get thinning hair or more chin hair, more spots. And that's because as our estrogen drops, our testosterone is still there, relatively higher, and that gives those wretched symptoms. Some women get really horrible dry, itchy skin, buzzing of the ears, tinnitus, restless legs when you can't stop your legs moving at night. Some women get more allergic or digestive changes. Lots of women get weight gain around the middle, which everyone absolutely hates. And then there are the vulval, vaginal, and urinary symptoms, and they're common. We now call those the genitourinary syndrome of the menopause. So don't get too depressed. Not every woman will get every symptom. So some of you will be sitting there, tick, 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 tick. Yeah, got them all. Some women may not have any symptoms, or they may not last very long. It's kind of the average is symptoms lasting is about 7 years, but that is the average. So some people have very little problems, but I do still see women in their 70s and 80s still getting and flushing and sweat. So it's incredibly variable. We always have to remember that symptoms may have other causes or contributing factors. And we've got to remember that midlife, it's a really busy time. We may have teenage kids, we may have elderly relatives that need looking after, busy jobs, looking after our partner, so much going on, and that obviously contributes. And sometimes some of the things that people think may be menopause, they may be due more to sort of the fact that it's such a busy life stage. So I'm going to just now remember I talked about the vulval, vaginal and urinary symptoms. I want to concentrate on this for a little while because it's really important, and because it's going to affect up to 80% of us at some stage of our lives. So that's a big number. So should have warned you, diagram coming up. So this is the vulva, just to so the vagina is the tube inside, and then the vulva is all the bits you can see on the outside. Doesn't include the anus, but you've got the clitoris with your clitoral hood, which covers it. You've got where the urethral open, where the urine comes out. You've got the vaginal opening, the introitus, and you've got your labour, your inner and outer labour. So all that area is the vulva, and it's really important that if we're talking to a doctor, we're describing the right bit of anatomy. And I think now there's so many funny words people use. I think if you've got daughters, it's worth teaching them the anatomical words. So let's go through the vaginal symptoms. So the vaginal vulval and bladder, the tissues are very sensitive to lack of estrogen. So they start to get thin and dry. So you can get vaginal dryness, irritation, soreness, itching and burning. You can notice a lack of lubrication. Some women actually, conversely, because things are so inflamed, they actually get a watery discharge rather than vaginal dryness. And I see a lot of women who are constantly getting swabs done for thrush and things like that, where in fact it's inflammatory discharge because they've got vaginal dryness. So you can imagine smears become really painful, sex can become painful, and obviously that's all going to reduce your sexual desire. And if any of you've had any painful, if your last smear was uncomfortable, it's definitely worth talking to your doctor about starting vaginal estrogen, which we're going to talk about in a moment. And it's got plenty of time to work before your next smear, and then you need to carry on with it long term. So vulval symptoms. So remember, this is a bit on the outside. So again, you can have irritation, soreness, itching and burning. Some women find the skin splits very easily, even when they're wiping themselves with toilet tissue, certainly can split during sex. And in fact, the labia and the clitoris can shrink down, and sometimes the clitoral hood can go over and hide the clitoris completely. And because of all the shrinkage, you get an impaired response to sexual stimulation, and orgasm is much more difficult if possible at all. Sex can be more painful, and of course then all this leads to reduced sexual desire. And we do recommend you actually examine your vulva once a month. Examine your breast, examine your vulva with a mirror, and just check what it looks like. And some of you will be a bit shocked when you look, because you'll see that it looks a lot less plump than it used to be. Then the urinary symptoms, so important to talk about these. So you may start finding you're going to the loo more often, which called frequency. You might find you have to suddenly think, oh, I've got to rush to the loo. And you may find you actually don't get there in time and leak. And there's a very common syndrome called latchkey syndrome. When you're out shopping or whatever, you get home, you put your key in your latch, suddenly your bladder says, I need to wee, and you don't get to the loo on time. A lot of women start waking up at night to pass urine more, or a lot of women find it stings when they pass urine, even if they haven't got an infection. The little urethra can prolapse out, and then women often start getting urinary tract infections after sex, or recurrent UTIs at any time, and those are all a sign that something needs to be done. So why is it important for us to diagnose this GSM? As I've said already, it'll affect most of us at some point in our lives. And it can start in the perimenopause. You can actually have it when you're breastfeeding as well, worth being aware of that. But it can start 5, 10, or even 20 years after the menopause. So often doctors aren't thinking, oh, it's to do with the menopause, it's lack of estrogen. And my mum, she doesn't mind me telling people, she was absolutely fine until she was 84. And at 84, she suddenly got the most awful symptoms. Now, the other thing is that the vaginal, vulval and bladder symptoms, unfortunately, once you start getting them, they will only get worse with time. So a lot of menopause symptoms you get through, you come out the other side, but these symptoms will only get worse with treatment. And the longer you have symptoms that are not treated, the longer it can take to get things back to how they should be. And this can really reduce quality of life. So I see women who've stopped riding their horse, stopped riding their bike, stopped wearing tight jeans, stopped wearing underwear, stopped going out because they're worried they're not going to find a loo in time. Obviously relationships break down because women just can't have sex because they feel like it's having razor blades put inside them. So it's a really important thing to sort out. And going onto the recurrent urinary tract infections, well, we all know elderly relatives who've been nursing homes who keep getting them, and then sometimes get sepsis, have to be rushed into hospital with urosepsis, which is life-threatening. Obviously, we do need to exclude other pathology. So sometimes there are other things causing this, so it is important to get an examination. But GSM, underreported. So women are embarrassed, so people don't necessarily volunteer their doctor they're getting these symptoms. We're not good at asking, so we're not very good at diagnosing them. And then even if we diagnose it, we're under-treating because women need to be on vaginal estrogen forever, not just for a short period of time. So we need to do better on this. But so think about what's happening with you. Think about what's happening with your elderly relatives. We all need to talk more about this. So diagnosing menopause is all about joining the dots. So working out all these different things, could it be due to the hormones? And it's a clinical diagnosis. So we don't do blood tests. So the FSH is very rarely needed unless you're having a menopause under the age of 40, when there's all sorts of blood tests we do to confirm the diagnosis and look for causes. So there's no point doing FSH if you're, certainly if you're 45 or over, and that's partly because it varies every day. Just depends on what day we catch it. Is it going up? Is it going down? So absolutely no point doing that. Now, your doctor might want to do blood tests, though, to exclude other causes, because obviously midlife, other things happen. It's not all just menopause. So depending on your symptoms, they might want to check your thyroid function. They might want to see if you've got anemia. They might want to look for inflammatory diseases. And as doctors, we always have this thing about red flags. So we're always just thinking, oh, does this sound like this? Or is it something different? So, you know, we always need to exclude anything serious. So, for instance, if someone's got digestive changes, change in bowel habit, we're not going to put that down to menopause. We're going to think, gosh, we need to check there isn't something serious going on in this lady's bowels. And if that's all fine, it could be menopause. So red flags are very important. So examination. So we do, if we're going to start on HRT, there's a few things we need to know. We need to know your blood pressure, and we need to know your height and weight. So if you're having a telephone consultation and you're thinking about starting HRT, that's fine. Go to a pharmacy and get your blood pressure done. Make sure you've got your height and weight for your GP. If you've got lots of vaginal, vulval or urinary symptoms, you might need an examination. But sometimes if people have got obvious symptoms, we can talk to them on the phone, give them the vaginal estrogen, and then if it's not getting better, examine you. But telephone consultations are usually okay for starting HRT. Blood pressure is really important. Most of the HRT we use now doesn't raise your blood pressure, but there's a lot of midlife women with undiagnosed blood pressure, and they reckon, especially as we go past the menopause. So it's really good practice to know your blood pressure and have it done at least once a year. So now I'm going to talk about these two things that happen to us when we lose our estrogen. So first thing is osteoporosis, which is a silent disease until you break something. So on one side, you've got healthy bone, which looks a bit like that. And as we lose estrogen, we lose the strength of our bone and the consistency of our bone, and it is much more likely to fracture. And 1 in 3 women over the age of 50 have osteoporosis. And as we get older, it goes up to 1 in 2 women will have osteoporosis, compared to 1 in 5 men. And when we have these thinner bones, we're much more susceptible to fractures with minimal trauma. So just tripping over. And first, often in our 50s, it's our wrist we break. And as we get older, it could be our hip, or it could be little fractures in our vertebral spine. So we'll see older women, a lot of older women have a sort of what we call kyphosis, when they sort of curve over like that. And that's because they've had lots of little fractures in their spine. These can be pain-free, or they can be very painful. But basically, if you're in your 50s and you have a wrist fracture, you need to have a look and see if you've get a DEXA scan to see if you've got thinning of the bones. And unfortunately, hip fractures are really serious. So if you have a hip fracture, which they're usually older women, but if 20 to 35% of those aged between 75 and 90 will die within a year of a hip fracture, and many more were coping fine at home on their own, but then can no longer live independently, because a hip fracture often needs major surgery, and it's difficult to recover from. And there's over 100,000 hip fractures per year in the UK, and that was 2020. So osteoporosis, again, remember I said it's important for the NHS. If we start improving our management of osteoporosis, we save an absolute fortune in misery, suffering, pain, but also NHS money. So what can we all do about, well, who gets osteoporosis? So if you have an early menopause, so under the age of 45, and even more so under the age of 40, you're more prone to getting it. If you've been on long courses of oral steroids, so things like prednisolone, if you've had bad asthma, those who've had anorexia or significant weight loss, so we build up our peak bone mass in our 30s, and if we haven't managed to do that because of anorexia, then we're starting at a lower bone strength before we hit the menopause. Unfortunately, family history is a big genetic. Is a big genetic link. So if your mum had osteoporosis, and particularly if she fractured a hip, that means that you're unfortunately more susceptible. And then there are some diseases that make it more difficult to absorb calcium and vitamin D to help our bones, things like celiac disease. And if you've had fragility fracture, so this is a fracture from standing high to less, that's a sign that you might have osteoporosis and we need to investigate you. And actually, you can go on to Royal Osteoporosis Society. They have an osteoporosis risk checker. You can actually just takes a few minutes. You can look at your personal risk. And if you want to go into more detail, you can go and look at the FRAX score, which is what we use. So we put in your details and you can do it yourself. And we look and see whether you're low risk, medium risk, or high risk. So that's, you can look at that in your own time. So what do we do to reduce our risk, as we're all so, you know, there's going to be, as I say, lots of us getting this. So not smoking, smoking can really damage our bones. Reducing alcohol intake is important. And then the exercise, we all need to be doing weight bearing, core strengthening and resistance training. So resistance training can be heavy gardening, yoga, Pilates, or using weights or resistance bands in the gym. And we know now that this weight and resistance training is really good for our muscles and our bones. So that's really important. Plenty of calcium and protein in our diet. So it's best to get calcium from your diet if possible. And you can go on, there's various calcium calculators you can go on to check whether you're getting enough daily calcium. And then daily vitamin D is really important, and we'll talk a bit more about that later. And if you are at high risk of osteoporosis, or you've already developed osteopenia, which is the stage before osteoporosis, or if you have osteoporosis, HRT is one of the first line options to help with that. And then just a little bit about cardiovascular disease, because unfortunately, again, when we lose our estrogen, we start getting more prone to this. And there's lots of things that affect our risk of cardiovascular disease. So there's a genetics, so a family history is a strong component, and where we come from. There's lots of metabolic things that affect it. So do we smoke? Have we got high blood pressure? Have we got diabetes? Have we got high lipids? Have we got lots of weight around the tummy? Lifestyle is important. Socioeconomic status can affect our risk. And then unfortunately, if you've had pregnancy-related conditions such as high blood pressure in pregnancy or gestational diabetes, you're more at risk. And then again, the age of menopause. So again, those women who've had an early menopause or very early menopause are at risk. So am I depressing you all thoroughly? We're now going to go positive and talk about all the things that can help with the symptoms and improve your health and reduce your risk of your osteoporosis and your cardiovascular disease. So all is not lost. So first thing I'm going to talk about, obviously, lifestyle. Now, every GP would like to talk to you about this every single consultation, but obviously we just don't have time. But it almost goes without saying, but I'm just going to zoom through a few little things on lifestyle very quickly. So I'm going to talk about reducing triggers for hot flushes and sweats, nutrition, movement, sleep, reducing stress and improving our environment, and obviously stopping smoking and reducing and ideally stopping alcohol. A lot of women find they actually can't tolerate alcohol very well once they get to midlife. And then a lot of other women, I think, because they're so stressed, they're actually turning to alcohol to help them cope, which again is not obviously not a good idea. So avoiding triggers. So some women find that they can improve things if they avoid alcohol and caffeine and spicy foods and smoking. And some people find that actually drinking hot drinks makes them worse. So drinking cool rather than hot drinks and keeping well hydrated. It's worth wearing cool, loose-fitting layers of clothing, and you can get basically the athletic stuff, that the sweat-wicking stuff is a good idea, particularly at night, so that if you're wearing cotton, you sweat a lot, then the cotton will be wet, whereas if you get a sweat-wicking garment, then hopefully you wouldn't. Sudden changes of temperature can make things worse. Now, there are lots of things on the market to help all menopausal women, and a few of them are worth considering. So fans, there's special cooling bed linen and pillows you can get to keep you cool. It's often worth, if you're sleeping with a partner, getting a separate lower tog duvet for you. And if you can, keep the bedroom cool with an open window if noise allows. Another last thing, which I find tricky, allow plenty of time for tasks to avoid stress. So easier said than done. So nutrition. I'm not going to talk a lot about this, but just briefly, you have to find what works for you. And it's pretty confusing out there, isn't it, with all the different suggestions on which sort of diets to follow. And actual crash diets really don't work. So it's more looking at small sustainable steps in your lifestyle and what you eat to improve your health. So What's got the most evidence really is a Mediterranean style diet. So that's more fruit and vegetables, more whole grains, lots of beans, nuts and seeds, lots of fish and seafood, and using olive oil, herbs and spices. So that's sort of something to look up. And certainly reducing ultra processed foods is a good idea. But you have to find something that works for you that you can stick with. Movement. So this is so important. So we need to be doing cardio exercise. I've talked about weighing exercise for the bones and strength and resistance training, and I've started because it's so important for all midlife women to start doing. And then something called NEAT you may not have heard of. So this is called non-exercise activity thermogenesis. So this is the moving around that we all do that's not sort of organized exercise, but it can be really good for our health. So, you know, just get up from your computer, get the stairs instead of the lift, park a bit further away from your office and walk to your office, all these things to just keep us moving. And if you can try and find activities you enjoy doing, so you're more likely to do it regularly, and especially if you arrange it to do it with friends, so you don't let friends down. And some people manage to do things at work at lunchtime. You know, if you'll go outside for a walk at lunchtime, just for a short while, that will make a lot of difference to your mental and your physical health. Sleep. So we talked a bit about sleep before, but we reckon it's 40 to 60% of women will get disturbed sleep, and that will lead to fatigue, worsening brain fog, low mood and low libido. And the problem with it may be that the menopause, the lack of estrogen might trigger poor sleep, but then it can become a habit and become a long-term problem, even if you go on HRT and the estrogen is restored. So how to manage sleep problems? So we want to try and sort out any menopause symptoms that are affecting sleep. Really worth getting outside first thing in the morning because the natural light helps reset our melatonin and our other hormones. Really worth restricting caffeine intake. So caffeine has quite a long half-life, so it takes 6 hours for us to get rid of half the caffeine. So if you're having caffeine in the afternoon, you may well still have quite a lot of it on board when you're trying to get to sleep. So maybe I usually try not to drink caffeine after midday. Alcohol, we've talked about. Some people think, oh, I'll have some alcohol, it'll help me sleep. But in fact, it really disrupts our sleep pattern. So it actually will make our sleep worse in the long run. So trying to reduce that. Avoiding our phones and our screens before bed, avoiding scrolling on Instagram, avoiding tackling tricky emails, all important to stop doing for a few hours before bed. And you want to try and get into a good sleep routine. And if you're really struggling, we have there's a special CBT, cognitive behavioral therapy for insomnia program that has really good evidence that it works. It's a 6-week program. There's a few of them around, but I recommend the one called from sleepio.com. And if you've had cancer, you can access this for free via the Macmillan website. So environment. So how can we improve our environment? So time outside in nature. Again, really important to be exposed to sunlight and even just natural light, being a bit more mindful about what we see when we're going out, so we're not just glued to our phones. Then trying to make sure that the light inside, there's plenty of light inside, trying to declutter, so have a clear work desk and a calm bedroom. If you could see my work desk now, you would say, I'm certainly not practicing what I preach, but hey, do as I say, not as I do, as I say, not as I do, isn't that the expression? Hopefully there are more supportive working environments now. And if things are really difficult work, you can talk to the managers about getting someone in to come and talk about how to help with supporting people at work. And then social environment. So don't just have your Facebook friends, try and actually meet friends in real life, try and do things that you enjoy. And anything that reduces your stress is going to help with your symptoms and your long-term health. So if it's if it's meditation or yoga or anything that reduces stress is a good idea. So other things to help with menopausal symptoms. So we're going to talk a little bit about supplements and complementary therapies, tiny bit about CBT, a bit about non-hormonal prescribed medication. Then we're going to talk in lots more detail about local estrogen, which most of us will need, and then HRT. So we're all doing well. Let's have a look and see how we're doing with time. Okay, so supplements. So I'm not going to talk much about supplements. We've got very little evidence for any supplements actually working, but if you find something that works for you, great. But it's important to say food first. So most people, if they've got a normal diet, healthy diet, and they haven't got other medical conditions, they don't need supplements. If you're vegan or vegetarian, you might need B12 and iron, but most things you won't need. But the thing we all need is vitamin D, because between 400 and 1,000 international units daily, at least from October to March, and that's everybody. That's men, female, male, female, children. But I tend to say for midlife, just take it all year round. And then, as I mentioned before, best to get the calcium in your diet rather than supplements. And there's a calcium calculator on the Royal Osteoporosis Society website. And I popped there, beware of men washing. There is a multi-billion pound in, I don't know how many thousands, millions, I don't know, but there's a big industry out there now trying to get your money. They've realized that menopause women are desperate. They will try all sorts of things. They'll spend a fortune on supplements. So people will buy really cheap supplements. They'll put them in a pink tin with menu on the front and charge 3-4 times as much. All sorts of weird gadgets. You've got menopause chocolates, you've got menopause teas, you've got menopause lady magnets, all sorts of stuff. So just have a think before. Some of the claims are just too good to be true. So just don't spend lots of money. If you want to try supplements, just get basic ones. You don't need to get special ones. So we talked about cognitive behavioral therapy for sleep. So we've also got good evidence that there's certain specific CBT techniques that can really help women with flushes and sweats and other symptoms. Very difficult to get CBT, especially this kind of specialized CBT. So I've put there a really good book that sort of guides you through, and it sort of helps you with your thinking processes and gives you resources to help you cope with the symptoms. So, and then there's non-hormonal prescribed medication. So we can use this for those who don't want to take HRT or for those who can't take HRT. And then we've got very low dose antidepressants. So these are not being used for their antidepressant effect. They're just being using for the fact that a side effect has been discovered, that they can reduce flushes and sweats in some women. So it's tiny doses. It's not the antidepressant doses. There's a tablet called oxybutynin, which we use for urinary problems, that as a side effect has shown that it can help with flushes and sweats. And then there's these painkillers or anti-epileptics called pregabalin and gabapentin that can help. Now, none of these are ideal because they're not designed to help, but they can have other side effects. But some women who can't take HRT do find they help. There's one called clonidine, which is actually licensed to help with flushes and sweats, but it's not very good, so I'll put it in brackets. The really exciting thing is we've got a new medication coming. So they've designed a completely new class of drugs that's been designed to help with flushes and sweats. And it works on the center in the brain that controls our temperature. And the studies have been really good. At the moment, you can get it only get it privately in this country, but NICE are looking at it at the moment, and we're just waiting to hear whether GPs can prescribe it, whether it's going to have to be menopause specialists, who's going to be allowed it, how much it's going to cost, etc., etc. But look out, the first one coming on the market is going to be called Veoza. And if you're struggling, if you've got breast cancer and you can't take HRT, this is going to be a really good thing to try. Now, the trials for women in breast cancer are going on at the moment, so we haven't got the results yet, but I think as menopause specialists, we'll be giving this to our breast cancer patients as soon as we get it to help with these symptoms. So this is a really exciting development. So now we're going to talk more about your vulvas, vaginas, and urinary health. So you have to be careful what you wash with. Some women benefit from vaginal moisturizers. There's various medication that can make vaginal dryness worse, like antihistamines. So if you're taking them, you don't need them, stop them. Really important, when you're having sex, you might find you need to use a lubricant. Now, there are lots of lubricants you could buy from your local chemist, but a lot of them have got not very good ingredients. They're not the right pH. They might have glitter or perfume or make everything tingle. Basically, they can upset the vagina even more and cause lots of symptoms. So the lubricants for sex that most menopause specialists recommend are the Yes products. So Yes do a vaginal and a water-based and a oil-based lubricant, and you can use them both. You can get those from yesyesYes.org. And there's another company that do one called Sutil, which is good. So those are the ones I recommend. Really important to remember, pelvic floor physios or women's health physios can really help if you've got urinary problems, if you've got prolapse, if you're struggling. They are really, but you have to ask your GP to refer you. And then we're going to talk about the amazing local vaginal estrogen. So this is so important for you and all your relatives. So what is local vaginal estrogen? So, and who can have it? So it's suitable for almost all women. We have to warn you about the patient information leaflet. Unfortunately, it lists all sorts of dangers which apply to old-fashioned oral HRT. None of them apply to vaginal estrogen, but if we don't warn you, you get the leaflet out and get worried and don't use it. So it's incredibly low dose estrogen. So you don't need anything to protect the lining of your womb. You don't need a progestogen. And this is really important. Even most women with breast cancer can use the lowest dose products, the estriol products. And if someone's on an aromatase inhibitor, then that needs a bit of discussion, but there are options there. And local estrogen, you can get it in a little tablet, a pessary, a cream, a gel, or a ring. And if you get GSM, and if you're not going to go on HRT, once you start using this, you need to use it forever. That's really important. Otherwise, if you stop it, the symptoms will start coming back again after a while. And we're also really important, at least 20%, probably far more women on HRT. So we say systemic HRT, so that's basically goes all around your body. At least 20% of women on HRT actually also need the local estrogen, ultra low dose put in where it's needed, and it's absolutely safe to have both long term. So let's just show. So this is the little tablet, and it might be called Vagifem or it might be called Vagirux. And now you can buy this over the counter. It's called Gina over the counter. This is fairly new. You have to be over 50. You can't have it if you've had breast cancer. Basically, the pharmacist has to go through a list of things. But if any of you want to try it before you go and see the doctor, you can do that. But obviously, long term, this is a treatment forever. We want you to go and get it from free from your GP. So that's a little tablet, and you can see you've got the inserter. You pop the inserter in, and then you press the little button at the end, and the white tablet comes out. A lot of people don't like using the applicator, so you can just use your finger instead. So that's one option. Then we have creams and gels. So the one at the bottom is called Blissell, which I like. And then the one at the top is actually it's not called Avestin anymore, it's called Estriol Cream. And they both come with applicators. So you just have a small amount. You can see with the Avestin cream, you've got just go up to the red line. So you draw up a little bit of amount, and then you pop that into your vagina. The good thing with the creams and the gels is you can also, if you're getting lots of vulval symptoms on the outside, you can just pop a little bit on your finger and pop it all over the vulva as well. And that's really good. You can put it around the urethra if you're getting lots of urinary symptoms. And some people find that it does improve their sensation and their sexual experience as well. So you can use a little pessary inside and the cream on the outside, or just use the cream or gel inside and outside. Some doctors might not know about that, but it is absolutely fine to do that. And then if you don't like the applicator, we've got something called Invagis pessary, which is another estrogen pessary that you just pop in, and that sort of melts and sort of comes in and goes on the outside as well. And this is my favorite thing, which is the e-string. So this, I can't see myself, so I don't know whether you can see all that, but basically this is a really flexible little tube. That's the size of my finger, so it's not too big. And this, you pop it in the vagina yourself, sits in the vagina for 3 months, providing a low dose of local estrogen every day. And then after 3 months, you whip it out and put a new one in. So it's a fantastic option for those who are clearly going to need local estrogen forever. And it's also a good option if you've got relatives who are in a nursing home. If you can get the district nurse to come in and pop one of those in every 3 months, that can really help people who are struggling with recurrent UTIs. So e-string is a really good option. Other options, so we've also got some pessaries called Intrarosa. I'm getting a meeting soon to try and get this on the formulary. They're going to be limited use for people probably who can't have other options. There's also a tablet called ospemifene, which is good for if people are getting awful symptoms and they've got issues and they can't go anywhere near their vagina. You may see advertised laser and radiofrequency treatment privately. This is incredibly expensive. We haven't got good evidence it works yet. We need a lot more research, so please don't waste your money. And again, pelvic floor exercise is important, and women's health physiotherapists you might need to guide you on how to do those if you're struggling. And so that's local estrogen, really, really important. And now we're going to talk about HRT. So at the moment, the current indications for prescribing HRT is to help control menopause symptoms, management of those with a POI and early menopause, as we talked about, to reduce their risk of cognitive, heart, blood vessel and bone problems, and then also osteoporosis prevention treatment. At the moment, they're saying if started under the age of 60. And HRT is the most effective option if you're having symptoms, if you've got no medical contraindications, you want to take it, it is the most effective option, and it does have benefits apart from symptom control. And so what do you need to know? You need to know how to use the HRT, side effects, the benefits and risks for you. So it's a very individual decision, but it's worth noting that you can have wildly fluctuating hormones in the perimenopause, so it can sometimes quite difficult to control all of your symptoms, and it can take really quite a while to find a suitable product and dose for you, and your requirements may change with time. So in the perimenopause, you might sometimes have lots of estrogen around, sometimes not. Postmenopause, it's more stable. So it can take a while to get the right thing for you, but there's no arbitrary time limit on how long you take it for. So I'm just going to talk a bit more about the cardiovascular benefits of HRT, because there's a window of opportunity for this. So we know that HRT can reduce your risk of getting or delay you getting cardiovascular disease if you start HRT within 10 years of your last period, preferably sooner than that. So obviously some people are not going to know when their last period is, but we know that if you get in with the estrogen before you've developed the problems with your blood vessels, it can delay that happening. Doesn't mean you can't stop it. It doesn't mean you can't start it later than that. But you're just potentially not going to get so many cardiovascular benefits. But the benefits to bone that we know that HRT really helps bone, and we know you get benefits for your bone health at whatever age you start HRT. So there's metabolic benefits of HRT as well. So when we have the menopause, the reduced estrogen leads to increased insulin resistance. So basically having to pour out more and more insulin to try and get the glucose into the cells. And HRT can reduce insulin resistance and reduce metabolic syndrome, and actually reduce the risk of getting type 2 diabetes, and it can lower your cholesterol and your LDL. So massive metabolic benefits to HRT. We also think it might reduce bowel cancer. But sadly, we do not have enough evidence to say that it reduces the risk of Alzheimer's dementia. So some private clinics are saying, oh, it definitely reduces your risk of Alzheimer's. The evidence so far is really conflicting. Some studies saying it increases the risk, some are saying it reduces the risk. We do think that if you're, again, someone with an early menopause, a very early menopause, having HRT may reduce dementia later on, and there's a specific group of people with a particular gene that makes them more prone to dementia. Some small studies shown that actually them having HRT is a good idea, but we can't blanket say, oh, take HRT to reduce the risk of dementia. And we really mustn't overpromise on the benefits of HRT. Not everybody wants it, not everybody needs it, and some people can't have it. So it's a very individual decision. So what are some issues and risks with HRT? So some medical conditions, it's contraindicated, and we'll consider those. The old-fashioned oral estrogen can increase the risk of blood clots, and some of the older progestins can as well. Some women get awful bleeding all over the place, we'll talk about, and some women get unacceptable side effects. It just doesn't work for them. And then there is a small increase in the risk of breast cancer, but this is related to the type of HRT you have and how long you have it for, and a tiny increased risk of ovarian cancer. But that risk is very small and compared to the benefits. So again, some private clinics are saying that's no increased risk at all, but the studies do show there's a risk, but it is small and it shouldn't necessarily put people off. So let's talk a bit about breast cancer, because it's so relevant to us all. So in the UK, we have a 1 in 7 lifetime risk of developing breast cancer, but we kind of all overestimate that risk. So this is a really old study, but it was looking at people thinking guessing what they might die of, and 39% thought it was going to be breast cancer. But actual causes of death, breast cancer, is only 4%. So we just nobody wants breast cancer. It can be a horrible thing to have, but it's not quite as it's not as common a cause of death as we think, and treatment has improved so much since this study was done anyway. So the survival rate's really good. So what are our risk factors for breast cancer? So female sex. So men do get breast cancer, but it's much, much rarer. And then another massive risk factor is increasing age. So 80% of breast cancers are diagnosed over 50, and the average age is about 61. And then family history can sometimes be relevant. Possibly 5 to 10% of breast cancers are due to a known genetic tendency. And there's probably about 5% of breast cancers where there is a gene, but we haven't identified it yet. And then some women have high risk breast conditions, and then lifestyle and reproductive factors are important as well. So we can't do anything about our sex, our increasing age, and our family history, but we can do something about our lifestyle and reproductive factors. So if you're worried about your family history, you can actually look up yourself. If you've got a family history of breast cancer or ovarian cancer, you can come to this guidance here, the CKS guidance, and it goes through all the list of, who needs referral to a family history clinic to assess risk. So we've got a brilliant family history breast clinic down in Taunton, and you can look up, or you can go to your doctor and say, can you look it up? Do I need to be referred? And what the family history clinic do is you fill in a massive questionnaire about your family history, and you work out, and they decide, oh, is this background risk, or does this need investigating? And then they look at, are you at moderate risk, high risk, or very high risk of developing breast cancer? And then they might initiate screening, more screening going on for longer and more frequent. And then there'll be a small group of people who will then be considered for genetic testing to look for specific gene mutations. So you have a look at that if you've got a family history of breast cancer. But it's so common, so a lot of us will have one relative with breast cancer. But if you have a first degree relative with breast cancer under the age of 40, or you have a first and a second degree relative at any age, then that are common reasons for going to the family history clinic. So this is just a little bit about lifestyle factors. So just showing that being overweight is an important factor. Alcohol is, lack of breastfeeding, 2% on HRT, but vast majority of breast cancers are not related to those factors, and sometimes it's just bad luck. So a little bit about breast cancer and HRT. So if you're general population risk, you haven't got a very strong history of breast cancer, then the HRT benefits usually far outweigh the risks. And that's partly because of, well, feeling better, but also because of the bone and heart and blood vessel benefits. If you've got a family history, HRT is often still an option, but you need to work out what degree of family history it is. And sometimes these people come to the clinic for me to counsel them. And if you've got a personal history of breast cancer, HRT is usually contraindicated, and we would want to try all other treatment options first. Very occasionally, if nothing works and someone is desperate and doesn't mind taking increased risk, we would discuss it with the oncologist and the menopause specialist. And a few women are now going on HRT, but it's a multidisciplinary discussion to see if that is an option. So is HRT the right option for you? So it depends on your preferences. It depends on your individual benefit versus risk discussion. Remember, I said that HRT is really important for those with an early menopause or very early menopause. If you've got a complex history, your doctor might have to send them to me to consider whether HRT is okay. And in some cases, women can't have oral estrogen, but they can have transdermal estrogen. And with complex people, we often have to start at a really low dose and go really slowly. So prescribing HRT, you don't need any initial screening or extra screening like smears or mammograms. We tend to prescribe for you and then review at 3 months and then review at least annually. As I said before, it can take a while to get the right dose for you and can be difficult when you're perimenopausal, and it doesn't suit everybody. And lifestyle is so important, but I do find sometimes that women are so, they're aching all over, they're not sleeping, they're irritable, they're unhappy. Sometimes if we get people on HRT, they're then much more motivated to then do the lifestyle stuff. So a little about estrogen. So we give estrogen for symptom control, and you can have patches, you can have gels. So you've got estrogel at the top in a pump, and you've got the Sandrina, which I prefer, which is the little sachet. It's more concentrated, so there's less to spread around, and it's better for traveling. You've got a spray called Lenzetto, which is another option. And then some women want the ease of oral estrogen, and that's absolutely fine if you're low risk and you haven't got an increased risk of blood clots, but we'd always change you over to transdermal estrogen by the age of 60 at the latest. Common side effects for estrogen. So not unusual when you start to get headaches, nausea, breast tenderness, fluid retention and bloating. And oral estrogen, some people do get indigestion and reduced libido. Often we don't start at too high a dose, so the lessen the risk of this. And sometimes people have to drop the dose a bit till they get used to it and then go up again. Those are very common side effects, especially if you haven't had estrogen around for a long time. And then endometrial protection. So this is via the use of progestogen. So who needs a progestogen? So if you still have a womb, you need a progestogen as well, because estrogen can make the line of the womb build up. And if you don't have the progestogen, it can get thicker and you can develop abnormal cells, and it can develop into endometrial cancer. So it's very important to always have your progestogen as prescribed. If you have a subtotal hysterectomy, that's when a bit of cervix is left behind. You might need progestogen. That's something to discuss with your doctor. And some women who've had hysterectomy, for instance, for severe endometriosis, might be advised to carry on with progestogen as well, in case if the surgeon feels there's lots of endometriosis they couldn't remove and we don't want to stimulate it with just estrogen, you might need a progestogen as well. And your doctor will decide whether you need sequential progestogen or continuous progestogen. And this depends on when your last period was. So if you haven't had a period for over a year, you can go on estrogen all the time and progestogen all the time. And that's designed not to give you any bleeding, but some people do get bleeding, certainly for the first 3 to 6 months. And then if you're still having periods, you go on sequential, so it's estrogen all the time and progestogen for half the month. And that's designed to give you a monthly bleed. But again, often people do bleed a bit all over the place for the first few months after starting it. So common side effects at the beginning with progestogen is actually similar to estrogen. So headaches, nausea, breast tenderness, fluid retention and bloating. Progestions can also give you constipation, acne and low mood. So micronized progesterone, I'm sure a lot of you are on this. So it's either called Gestan or Gepitrix. We're trying to prescribe everybody Gepitrix in Somerset. And this is often the preferred option. And why is that? This is because it has, do you remember I said, oh no, go back again. Do you remember I said the risk of breast cancer depends on the type of and duration of HRT. So we know that with micronized progesterone, there's little or no increase in breast cancer risk for the first 5 years of use, and then only a gradual slight increase with prolonged use. And it seems to be the safest of all the progestogens. So that's why a lot of doctors and patients want it. Doesn't cause blood clotting, no neutral effect on coagulation. It's less androgenic, so that means it's less likely to cause acne and greasy skin than some of the other progestogens. Doesn't affect your cholesterol badly, and some women find it's calming and helps them sleep. But unfortunately, it's not as good at keeping the line of the womb thin as we thought it was. So some women do have bleeding problems, and some women find it makes them feel moody, because it's the same hormone as we get for the people that struggle with PMS. So it's kind of Marmite. So some people absolutely love micronized progesterone and some people absolutely hate it. And then there's other options for progestogens. So if you're on micronized progestogen and it's really upsetting your mood or giving you symptoms, you can use it vaginally. This is off licensing, but you can use it, but it's really important you use it in the same dose and same regime as orally. There are some private clinics who are saying you can halve the dose if you use it vaginally. Unfortunately, that's not safe. And if you're doing that, you need to talk to your doctor about getting a scan to check the line of your womb. Then we've got lots of synthetic progestogens that can be transdermal or oral. And then we've also got the coil with the hormone in it. And that's now we can use the three of the coils. We can use Mirena, or Livicert, or Benedexa, and that sits in the vagina, in the vagina, goes through the vagina, through the cervix, and sits in the uterus like that. And it lasts 5 years for endometrial protection. And then some people like the ease of combined products. So you can get combined patches with both hormones in, and you can get combined tablets with both hormones in. So they can be good options as well. It's really personal preference and what suits you. Now, this is this is new. There's been a lot of talk about high estrogen doses recently. So this is the guideline that came out. It was a consensus guideline from all sorts of different specialists, gynecologists, menopause specialists, GPs, and it's basically trying to clarify what's a high dose and what isn't. And so it's clarified all the different things into ultra low dose, standard, moderate, and high dose. So this is the maximum. The high dose is the maximum recommended dose. So that's 4 measures of estrogel, 3 milligrams of Sandrina, although I usually don't need to go that high. 6 sprays of Lenzetto. Again, I don't tend to go past 4. The 100 microgram patch or 4 milligrams of oral. Again, don't tend to go that high on the oral. So a lot of you might be on the basic 4 measures of estrogel or the 100 microgram patch. We don't suggest going any higher than those doses. There will be occasional times when much younger women need to go higher, but we don't recommend going higher. And some of you may well be on much higher doses, and you may be reassured by your private clinic that, oh, your estrogen levels are all right, so you just need a higher dose. But we are moving away from doing estradiol levels, unfortunately, because they are affected by many different factors, both sort of factors with the patient's skin, the time of day, what the patient's metabolism is doing, and how the medication is metabolized in the body. So the big issue with estradiol blood tests is that they do not reliably indicate the amount of estrogen in the body. So we can't say that, oh, you're on 2-3 times the maximum dose of patch, but your level's low. We can't say that's safe because the blood tests aren't reliable. So if you are in that situation, you do need to talk to your GP about slowly reducing or ideally changing to a different HRT. So we do occasionally, the message about this is taking a while to get through to everybody, but we do occasionally still use estradiol levels. So for instance, if you're on the maximum dose of gel or patch, because there you can't do estradiol levels on oral estrogen or the spray, but if you're on the maximum dose of gel or patch, so 4 measures of estrogel or 100 microgram patch, and if you're still getting a lot of symptoms, we might do an estrogen level. And if it's really low, then that shows you're just not absorbing. But what we would do then is change the product rather than increasing the dose. We don't just suggest, no point going up and up on a dose that you're not getting on well with. And as I mentioned, occasionally those with really early menopause might need a higher dose. And then because of that, there's been lots of discussion about what dose of progesterone is suitable, depending on the dose. And because we know that micronized progesterone isn't brilliant, as good as it thought it was, and because loads of women are getting lots of bleeding, that the guidelines have changed. And again, this is non-urgent, but slowly we're educating GPs about this. So basically the thing to look at here is that if you're on the maximum dose, so 100 microgram patch or 4 measures of estrogel, you need to double up your micronized progesterone. So either if you're taking it all the time, it's 2 tablets instead of 1. And if you're taking it half the month, it's 3 instead of 2. But you can look up all this chart and discuss it with your doctor. On this is a leaflet all about management of unscheduled bleeding on HRT. It explains about it. Women's Health Concern is a really good website. It's the patient arm of the British Menopause Society. It's got lots of brilliant documents and fact sheets on it. But you can look up, and the tables I showed you are in this document. So if you're getting lots of bleeding, we might up your progesterone at a lower dose, but now everybody on the highest dose needs to think about upping their micronized progesterone or reducing down to a slightly lower dose of estrogen or trying a different progesterone, or ideally having, if you're on high dose, having the Mirena, because that's the best protection for your endometrium. So have a look at that document for those of you getting problems with your bleeding. So when will I feel better? Right, so the flushes and sweats, often the first, they often get better within a few months, but other symptoms can take a lot longer. But it can take at least up to 3 months to notice a difference on a particular dose. So we don't suggest going up too quickly. I know some private clinics put people up and up and up really quickly every few weeks, but you really need to give it a good length of time to see what's helping, because there's actually no point being on a higher dose than you need. And if HRT is not helping much, we have to think, are there other causes? Are there contributing factors? What's happening with the lifestyle? But also, if you've got a patch, is the patch sticking properly? Are you putting it on the right place? With the gel, are you rubbing it in or letting it dry? So you shouldn't be rubbing your gel in, you should just be letting it dry. your patches, best place to put patches, the Lenzetto spray and the gel is thigh, particularly in the thigh. So there's lots of things to think about if the HRT isn't helping much. So if you want to come off HRT, so nowadays there's no arbitrary time limit. So long time ago, when we were worried about HRT, it used to be lowest possible dose for the shortest possible time. That's gone out the window now. It's the lowest dose that sorts out your symptoms, and you just need an annual look at your personal individual benefits versus risks. And a lot of women are deciding to stay on HRT long term into old age. You can reduce the dose as you get older. As I said before, really important to move from oral to transdermal by the age of 60. But we know that bone is very sensitive to estrogen, so even very small, low doses of estrogen are protective to bones as we get older. And if you do want to come off HRT, try and do it gradually, because that can lessen sort of any side effects. And some people come off HRT and they'll be absolutely fine. If you were destined to have symptoms for, let's say, 5 years, and you took HRT for the first 4 years, if you came off HRT, you'd still be having that 1 year of symptoms, because that's what your body was going to do. So, but it's a myth that HRT just pushes the symptoms down the line. But you don't have to feel, unless you develop some condition, you don't have to feel that you have to stop HRT. Contraception, just remember HRT isn't a contraceptive, so that's something you have to consider. Just a reminder about the prepayment certificate, if you don't know about it. Started last year, annual cost of £19.80, and you can have as much HRT and local estrogen as you need, but it only includes products that are licensed, so it doesn't include testosterone at the moment. That's where you apply. If you're on lots of other medication, you might be better off with the standard certificate. But we need lots more research on what are the safe doses of estrogen, what are the safe doses of progesterone to help with your endometrial protection, more on the role of testosterone, more on options for women with breast cancer, and more on the effects of HRT and dementia risk. But there's a lot of, as I say, polarization and misinformation on social media, but all these different societies do generally agree on their guidelines, but not 100%, but they both mainly agree. Lots of myths about HRT. Some people, we've seen that you can't be too young necessarily to go through the menopause. There aren't age barriers to starting HRT. You may still be having periods, but perimenopausal symptoms. Migraine sufferers can have estrogen through the skin. High blood pressure, you can have estrogen through the skin if you're overweight. Again, the same. You may well still be able to have HRT if you've got a family history of breast cancer, ovarian cancer. And again, you may well with a family history or personal history of blood clots. Sometimes these can be complicated and you might need specialist advice. It's gone out of the window. You don't have to stop it after 5 years or at the age of 60 or if you're starting bleeding. And then a few other myths at the moment. I would say you don't have to have a blood test. HRT will not cure everything. And again, it's not true that without HRT you will inevitably get lots of chronic diseases. Lifestyle and other things are really important. And it's certainly not true that everyone needs testosterone. And we're going to talk about that. So we've got just about, we'll whiz through female sexual desire. I'm aware that we've got questions too, but this is an important one. So female sexual desire is really complicated. There's lots of different things that contribute to our low libido. So we might be getting awful menopausal symptoms. We might have other illnesses. Sex might be painful. We might be on medication that reduces our libido, like antidepressants. We might have relationship issues. And I'm afraid being in a long-term relationship has been shown to reduce desire, sadly. Spontaneous desire anyway, possibly not responsive desire. Being tired, stressed, lack of privacy, negative emotions, past trauma, body image issues, culture, religion, gender identity, all these things kind of go into factors to reducing our sexual desire. Some really good books. So Mind the Gap actually talks all about this spontaneous desire, which we have when we first meet somebody. That goes after a year or so. And that then hopefully we move into responsive desire when we don't, last thing we want to do is have sex. But if we do start having sex with our partner, we do then start to enjoy it. So that's a useful book. And then Come As You Are is another good one. So prescribing testosterone, I know we had lots of questions about this. Who can prescribe it and to whom? So our NICE guidelines say that we can consider prescribing testosterone. They only say for postmenopausal women, but we do sometimes give it to perimenopausal women with a low libido that's distressing them if HRT alone is not effective. So you do need to be on HRT first. But it's worth pointing out that testosterone is very different to estrogen. Our testosterone doesn't drop dramatically in the same way that estrogen does. So when our ovaries give up producing estrogen, they carry on producing testosterone, and also our adrenal glands produce testosterone. And so our highest testosterone is in our mid-20s. It sort of comes down, plateaus around midlife, and sometimes goes up as we get older. And that's, as I say, we do, some older women get terrible hair thinning and chin hair and spots, and that's partly because they've got more testosterone again. So testosterone is most helpful for those women who've had their ovaries removed because they've suddenly lost 50% of their testosterone production. But it's very different, as I say, to estrogen, despite what some people say. And also, as I say, we've got lots of other factors that can affect a woman's libido. So if we're thinking about prescribing testosterone, really important to get the estrogen dose right first. So you don't have to be on maximum dose, but you've got to be if you're still getting loads of flushes and night sweats, then you're probably not on enough estrogen. And if we just, and we don't tend to give testosterone on its own, because the body, if it's desperate for estrogen, it tends to cleverly convert the testosterone into estrogen. And then many women who are asking for testosterone are still on oral estrogen, and this actually reduces libido. So we want to get you onto transdermal estrogen first. And a lot of women, as I say, still have symptoms of low estrogen and still have GSM symptoms. So the last thing we want to do is, if it works for you, improves your libido, having sex hurts, agony, splits, can't have sex for weeks, disaster. So we've really got to make sure you're not getting any of those GSM symptoms. So once these things are sorted out, we can consider starting on testosterone, but your GP might have to refer you to me unless they've done training with me so they know what to do. Some GPs are trying to help and are prescribing it, but not doing all the proper counselling. Some women are buying it off the internet and using far too much, which is really, really scary. And you can get into trouble with having too much estrogen, and there are potential side effects and issues. That we are lucky at the moment in Somerset, it is we call green, so GPs, if they know what they're doing, are allowed to prescribe it, and they're certainly allowed to carry on prescribing it if I've initiated it. But you need to have your testosterone checked before and during treatment. We only check your testosterone level before treatment just to check that you don't already have a high level. It's not diagnostic, so the actual testosterone level we can't say, oh, it's low, you need testosterone, or it's high, or it's medium, maybe you don't. Unfortunately, the blood tests we got are not very accurate at the low level. They're male tests, and they're not very accurate at the low female levels. So it's just purely, we're just doing the blood test to make sure it's not too high already. And then you have to have regular checking, and you have to watch for side effects. There are side effects, so you sometimes have to reduce the dose or stop. And it's a bit of a slow burner. It can take a while to make a difference, but if it's not helping by 6 months, it's not going to help, and it's not the missing link for you. But a lot of women want to try it, and I completely understand that, and I prescribe it a lot, but it is being oversold at the moment, particularly by private doctors. So what can we do? On the NHS, we don't have a licensed product for women, so we have to use the male options. And the ones we use nowadays are the little Testogel sachets and the pump. The Testogel sachets, a man would use a whole sachet a day, but we have to make it last at least 8 days. And the testosterone pump you use 3 times a week. There is something called Androfen, which is licensed for women, but it's only available privately. If you've been given the Testogel pump or Testovan pump, go back to your doctor, because they can't possibly use them to give the right dose for women, so they can be a lot of women are overdosing on those. There are implants, but they're not usually recommended, and they're not available in Somerset. Now, anecdotally, you may well have heard a lot of women coming wanting testosterone because they've heard it helps with their mood, their cognition, their energy levels, their stamina, the bones and muscles. All the studies so far have not shown any of these benefits. Luckily, there are more studies going on now, but at the moment, we only have evidence that it helps the libido in some women. So we're not just going to, that's why we're not dishing it out to everybody, because we just haven't got the evidence yet. A little bit about the service. So any Somerset doctor can write a letter to the Somerset NHS Menopause Service, and I triage all the letters, and a lot of things I can do an advice and guidance letter back to your GP to tell them what to do, and then I reserve the seeing the patients face to face for the really complex patients. And sometimes I'm doing a advice and guidance holding letter saying, try this, and we'll see them in clinic. And sometimes it can all be sorted out by the letter. If I saw everybody who wanted to be seen, the waiting list would be 3 years probably. So we have to do it like that. At the moment, we're booking for February time, I think. And it's just for complex patients. So we want GPs or nurses to ask people in the practice first before writing to the service. And I run this from Glastonbury Surgery. If it's a long way for you to come, you can when you get the appointment, via text appointment instead. At the moment, unfortunately, the turnaround for advice and guidance is about 4 weeks because we're very busy, but it's variable. You can look on, if you go to Glastonbury Surgery website, one of the headers says Somerset NHS Menopause Service, and that webpage has got lots of information about HRT and how the service works as well. And I run the service, and then I've got another doctor, Dr Aldridge, who sees patients as well. So how to talk to your GP if you want to go to if you're thinking you want to start HRT, and you don't know your practice very well, it's worth asking the receptionist who's good at women's health, who knows more about HRT. They might have an idea of who to avoid and who to go to. We used to say ask for a double appointment if possible, but that's nigh on impossible now. But it can take a long time to go through stuff. You can tell them that you've been to this webinar, so you've learned a lot. But often we need to talk to you, give you stuff to read, and then see you again. So it often takes 2 appointments. Do your research first. And if you're thinking about HRT or you think your symptoms might be perimenopausal or menopausal, say that at the beginning of the appointment so that the GP knows which track to go on. Resources. So these are some good resources. I've already mentioned the Women's Health Concern.org, which is a patient arm of the BMS. Rock My Menopause is good. The Royal Osteoporosis Society I mentioned. Daisy Network is brilliant for those who've had an early or very early menopause. Breast Cancer Now is great for those who've had breast cancer, and I've already mentioned the webpage for the menopause service. And here are a few books. There's so many books out there now, aren't there? Here's a few I recommend. So The Science of Menopause is a good book with lots of diagrams by Dr Philippa Kay. I actually peer reviewed that, so I know it's good. The Complete Guide to Peri and Early Menopause is really good for younger people. And then The Complete Guide to the Menopause by Dr Mukherjee is great for those who can't take HRT. So this is the doctor who had breast cancer in her early 40s. So she talks about all the ways to reduce stress and all the lifestyle stuff you can do. And unlike all the other books, it doesn't have pages and pages about how wonderful HRT is, which is really hard for women who can't take it. And then finally, the Living Well Through the Menopause is the CBT book I mentioned before. And then this is a really good leaflet that you can, which all about understanding menopause. Again, I edited this, so I know it's good and reliable. This just runs through all about what is menopause, genital syndrome, everything like that. And it's actually got a symptom checker in it for both for general menopause symptoms and for the genitourinary issues. So that's good. And you can basically get a PDF of that on your phone, or with that booklet will download. Okay, so I think we've just got quite some time for some questions. Obviously, if people have to go understand, we're going to stop the recording.